It's my pleasure to introduce our next speaker, Dr. Ming-Huei Cheng. Dr. Ming-Huei Cheng is Chief of the Center of Tissue Engineering, Senior Professor, Department of Plastic and Reconstructive Surgery at Changgung Memorial Hospital. He has a total of 230 peer-reviewed papers, 41 book chapters, and he's recently edited a textbook. I have no idea how he has the time. He was my mentor, my research mentor for microsurgery when I was a fellow at Changgung Memorial. And this talk is going to be lymph node transplants. How do they work? It's a common question I get asked by everyone. I get asked by patients, I get asked by other clinicians, and I've heard Ming-Huei give this talk. It's a beautiful talk with beautiful images. So Ming-Huei, take it away. Thank you.
Good morning. It's my great honor and privilege to join the Boston Lymphatic Symposium 2021. Today, I'd like to share with you my experience in vascularized lymph node transplantation. How do they work? This is my disclosure. In 2015, we represent our experience in lymphedema surgery and report the severity using chance lymphedema grading. Based on circumferential difference from 10 to 19%, 20 to 29%, 30 to 39%, and greater than 40% as a grade 1, 2, 3, and 4. And we also add the lymphocytic finding with a partial occlusion and total occlusion, then to choose the most appropriate procedure to treat extremity lymphedema. The indications for vascularized lymph node transfer include grade 2 to 4 chance lymphedema, total obstruction on lymphocytography, repeat episodes of cellulitis, failure to rehabilitation. The contraindication were recurrence or distant metastasis. This is an example of total obstruction on lymphocytography, T5. As you can see, no acidic lymph node presented and with a diffuse entire lymphedema backflow. We also use ICG to mapping the pattern lymphatic duct. If a patient presents with a partial obstruction on lymphocytography, the indocyanine green lymphography is very useful to identify the pattern lymphatic duct for possible lymphovenous bypass. If no pattern lymphatic duct, such as this case showing diffuse dermal backflow, the patient is also indicated for vascularized lymph node transfer. I would like to share with you some example of vascularized growing lymph node transfer to right wrist for grade 2 lymphedema. The patient presents with a cellulitis, and after vascularized growing lymph node transfer to the wrist, at post of 95 months of follow-up, the reduction rate reached 82% above elbow, 50% below elbow. No post-op compression garment required. Another case, grade 4 lymphedema. After 63 months of vascularized growing lymph node transfer, the reduction rate reached 90% above elbow, 50% below elbow. We were able to excise all the skin pedal at 1 year post-op to achieve better cosmesis. Another example, grade 4 lymphedema using vascularized growing lymph node transfer to the wrist, the flat dissection, the recipient site preparation using radial artery dorsal branch and cephalic vein. This is a pre-op picture, post-op 4 months. The reduction rate was 30% above elbow. Post-op 4 years, the reduction rate was 60%. The skin pedal were excised to achieve better cosmesis. At 11 years of follow-up, the reduction rate continued to improve to 70% without compression garment needed. Then I'd like to introduce vascularized segmental lymph node transfer to the wrist. Here example, pre-op, the patient with a compliance of compression garment, but have cellulitis 3 times. We transfer the segmental lymph node flap to the volar side of the forearm. At 3 months follow-up, the reduction rate was 8% above elbow, 14% below elbow. At 33 months of follow-up, the reduction rate improved to 95% above elbow, 80% below elbow. Another case present with right upper limb lymphedema with cellulitis 2 times per year with a symptom for 4 years. After vascularized segmental lymph node transfer to the wrist, the reduction rate was 10% above elbow, 12% below elbow at 3 months of follow-up. At 13 months of follow-up, the reduction rate improved to 50% above elbow, 55% below elbow. The skin pedal was excised to achieve better cosmesis again. At 33 months of follow-up, the reduction rate improved to 90% above elbow and 95% below elbow. Another case at the left side, primary lymphedema grade 4. The patient with a compression garment for 10 years and underwent CTT for 5 years with cellulitis 2 times per year. We transferred vascularized segmental lymph node flap to the left angle. Initially, the reduction rate was not that great. After 36 months of follow-up, the reduction rate was 55% above knee, 56% below knee, and 38% above ankle. When patient present with extremity lymphedema, there is a significant increase in both subcutaneous and intramuscular compartment pressure. In 2009, we proposed the mechanism of vascularized lymph node transfer, include a pump mechanism via the natural lymphovenous channel, and followed by catchment effect and gravity effect. This cartoon can help you to understand how the vascular lymph node transfer works. After anastomosis, the perfusion from artery to vein and the vascular lymph node start to absorb the lymph drainage into the venous system, and followed by catchment effect and the gravity effect. Now I'd like to show some evidence of the mechanism of vascularized lymph node transfer. When we inject TC99 to the distal wet spaces, as a pre-op, you can see diffuse dermal backflow on this lymphocytography. After vascular lymph node transfer to the wrist, 4 months of follow-up, the diffuse dermal backflow significantly decreased at 120 minutes. Then we conduct this animal study using SD rate, and we divide into 3 groups of the ICG injection. The group 1 with a lymph node flap edge ICG injection n equal to 12, and the second group is the vascular lymph node flap with a node direct injection with the ICG, and the third group was the non-lymph node flap with a flap edge injection with ICG. Here is the picture showing the lymph node flap edge injection. As you can see, the ICG fluorescent move from distal edge and to the pedicle vein, as in this yellow arrow. And when we inject the ICG to the lymph node directly, and we can see the beautiful pedicle vein got fluorescent immediately. When we injection the ICG to the non-flap edge, such as this DIP flap of the SD rate, as you can see, after 30 minutes, there's no pedicle vein got fluorescent. So here is the result. The group 1, the lymph node flap edge injection, with an average 153 second with the pedicle got fluorescent. And second group of vascular lymph node direct injection, it was average 13 seconds to get the pedicle vein got fluorescent. And the third group, after 30 minutes, no fluorescent at the pedicle vein. We also conduct a clinical study to investigate the mechanism of the vascular lymph node transfer. The first group is a vascular lymph node transfer flap with the ICG edge injection. The second group is a vascular lymph node flap with a node direct injection. The third group was the non-lymph node flap edge injection, n equal to 12. The third group with a ALT in 6 cases and form in 6 cases. This video showing the vascular lymph node flap with the ICG edge injection. As you can see, the ICG move from flap edge and then gradually to the pedicle and get the pedicle fluorescence at 6 minutes post ICG injection. This was the segmental lymph node transfer to the volar side of the forearm, and here is a visible lymph node being held by a forceps. Then we inject the ICG to the node directly, and pedicle is here with the loop. Then when we inject ICG, you can see after a couple minutes, in average 23 seconds, and you can see the pedicle vein got fluorescence. This is direct evidence showing the vascularized lymph node have a connection to the venous system. And here is the result showing the vascularized lymph node flap edge injection and the vascular lymph node flap node direct injection and non-vascularized lymph node flap edge injection pictures. This is a summary of this study. For the first group, vascularized flap edge injection, the average latency was 350 seconds. For the second group, vascularized lymph node flap with a node direct injection, the average latency was 23 seconds. For the non-vascular lymph node flap edge injection, number name showing pedicle got fluorescent. Maybe people will say, I was lucky to inject the ICG to the venous, to menu or to the capillary. So we are able to see the ICG going to the pedicle vein, then pedicle vein got fluorescent. So we further conduct this study. When we prepare the donor site after the flap dissection, and we were lucky to have to collect some lymph. And then we put the lymph into this flask and mix it with the ICG. Then we bring the vascularized segmental lymph node flap with the pedicle still in continuity and to on top of this flask and immerse into the lymph. So here you can see the flap, the pedicle is here, and the level of the pedicle actually was higher than the flask. So after 10 minutes and 14 seconds, then you can see the pedicle got fluorescent and include the fluorescence of the ICG going to the pedicle vein. Here, when you see we move around the pedicle vein with a basal loop, and you can see the fluorescence drain beautifully from the flask and to the pedicle vein. So this is the direct evidence showing the vascular lymph node flap was able to absorb the lymph mixed with the ICG drainage into the pedicle vein, then the pedicle vein got fluorescence. So on this cartoon summary, the lymph node play an important role in the lymph drainage. The lymph node was known with the efferent duct bring the lymph into the lymph node, then drain out of the lymph via the efferent duct. But the artery also bring the blood into this lymph node, and then the venous system also drainage part of the lymph through the venous system. We believe there's a connection inside the vascular lymph node, so there's a natural connection with the venous system and the venous lymphatic system. When we transfer the vascular lymph node to the distal recipient side, we developed this retrograde manual lymphatic drainage technique using sphygmomanometry. First, after lymph node transfer to the distal recipient side, either the angle or the rest, we use the sphygmomanometry start from 90 millimercury, and each time with a 5 minutes, then and compress the first in the flap itself for 5 minutes, then to the distal part for 5 minutes, then to the plasma part for 5 minutes. Then we found out that the lymph can drainage due to the catchment effect and gravity effect. So when we compress the lymph and release, it's like a pump or sponge. They are able to absorb more lymph into this lymph node and drainage into the venous system. And this cartoon, again, further remind you that the vascular lymph node is very powerful as a pump machine, but sometimes still not enough to drainage the accumulated lymph, especially in the lower extremity. So we developed this retrograde lymphatic manual drainage system to help the lymph node to drainage the lymph into the venous system, especially in the lower extremity. When we compare the CDT group and the vascular lymph node flap transfer group, we found the vascular lymph node flap with a significantly improvement in circumferential reduction rate and improvement of circumferential difference, and also decrease the episodes of cellulitis at 36 months of follow-up. We also review the literature from 2006 to 2018, and we found the outcome between the proximal recipient side and distal recipient side, and we found the distal recipient side have a greater cases with a total 528 cases and with a mean reduction rate of 40%, which was significantly greater than the proximal recipient side with 174 cases with an average circumferential reduction rate of 24.8%. How about long-term follow-up? We usually excise the skin pedal at 1 year after the vascular lymph node transfer. Such as in this case, we inject the ICG in the proximal side of the transfer lymph node in the middle egg. And as you can see, the ICG move from proximal to distal to reach the transfer lymph node flap. This is showing the lymph node can act as a pump machine to absorb the lymph from proximal to distal using the catchment effect and followed by gravity effect. I'm very honored to join the Boston Lymphatic Symposium, and in 2013 we start to share our experience and host the World Symposium for Lymphedema surgery every 3 years. And hopefully I will see you soon in Taiwan after the pandemic. In conclusion, we propose the pump mechanism of vascular lymph node transfer for drainage of the lymph into venous system in 2009. And we prove lymph was drained from transfer lymph node to the venous system, followed by catchment effect and gravity effect. We also prove that the lymph was drained from the interstitial to the transfer lymph node and then into the pedicle vein. Thank you for your attention.
Ming-Huei, good evening. It's also close to midnight your time. How are you?
How are you?
Good. Thank you for joining us, and thanks for sharing that important work. You know, the question comes up all the time, and I think a picture or a video says 1,000 words and more. And I think that's exactly what we were looking to accomplish with that. So thank you for doing that. You know, I have a question for you. So given your understanding of the physiology of a lymph node transplant, it obviously explains your bias, Ming-Huei Cheng's bias, that, for example, that all these lymph nodes should be placed distally. But you know, there is discussion about double level transfers more proximally. In your opinion, do you think there's any role for a proximal transfer with or without a distal transfer?
Thank you very much for including me. Actually, a couple of years ago, I also published a paper to compare proximal placement of the lymph node or distal. And we found out the distal recipient side had a significantly better outcome than proximal recipient side. So after that study, I always place the lymph node to the distal recipient side. And I also did double lymph node transfer in the very beginning. But I found out the proximal lymph node actually didn't work. So right now, I only transfer one lymph node to the distal recipient side.
I'm the same right now. I can definitely think of an argument to go more proximal, but I just want to see if anybody on the panel here or from around the world has a contrarian view. Yeah, let's, Jaume, you want to go first and then Hide?
Yeah, just hello everybody. Congratulations for this wonderful symposium, Ming-Huei, like always, great talk. It's a difficult question because also when Ming-Huei Cheng comparing, you know, the location, it's very difficult to find, you know, the same patients, you know, with the same characteristic to be comparable. You know, I think is every patient has different stage of lymphedema, even different lymphatic system. So it's very difficult to say that is better than the one. For me, what is a good argument to put proximal, especially in breast cancer with the lymphedema, is because we like to clean all the scarring tissue about the venous, the axillary vein, because it's also important, the venous pressure. And it has been demonstrated that when you have a high pressure, whatever you use as a pumping or as a lymph node shunt is not going to work well if the vein is so high. And also, yeah, just more than 100 years ago, you know, Kalima, a Finnish surgeon, demonstrated that only cleaning, removing all the scarring tissue and improving the venous axillary pressure, the lymphedema reduced 20%. And this is happening in 1916. So for me, it's important, you know, when you have a scarring tissue, put some, you know, tissue, fresh tissue, and clean everything. And on the other hand, obviously, you need to try to look for the best for every patient because everyone is different.
Awesome. Well, let's go to Hide, and then I want to give Ming-Huei the last word on this.
Yeah, I completely agree with Dr. Masia. I think it is very important for upper extremity lymphedema to release the scar tissue in the axillary veins. And I've had good results with the proximally placed flaps, as I'm going to talk in the next talk. But I do agree with Dr. Masia and Dr. Nelligan.
I'd like to respond to this question. Actually, a couple of years ago, we published a paper in Annals Surgery, and we compare with the DIP flap without DIP flap along with the vascular lymph node transfer. So we found out that the DIP flap transfer doesn't help for reduce the lymphedema. That's number one. Number two, if you transfer the lymph node to axilla, and for the low extremity lymphedema caused by gynecologic cancer, ovarian cancer, or cervical cancer, it's better you place the lymph node to the pelvis, not the groin, because the groin lymph node in this kind of gynecologic cancer patient they're almost normal. So you don't have to have a new lymph node put on the growing for additional lymph node. The obstruction is on the pelvis. So same thing as this. I think in the other study, we also knowing that if you put the lymph node on the proximal, you look like you have to have the water from the well, draw the water from the well, very need a lot of energy. So the power probably not adequate. Most time, if you place the lymph node at the axilla, usually can improve upper arm, not the forearm. Very difficult. Thank you.
Thanks, Ming-Huei. I appreciate that response. And, you know, I kind of asked the question following Jaume's lead of what he taught me when I attended the BBM, that it's our job to poke the skunk and, you know, get some discussion going. And it's also to show our audience that you can bring all the world experts together and they're going to be very thoughtful in their responses, but their answers are also going to be very different. So thanks, guys. Really appreciate it. For time, we're going to move on to our next speaker.